Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you so much for joining us for today's Lunch and Learn session. We're very excited to build this session around the 20th anniversary of the HHS Office of the National Coordinator for Health Information Technology, or ONC. Just to give you a sense of how our conversation is going to go today, I'll introduce our panelists and then ask them some questions. We'll have a conversation that we're scheduled for 90 minutes, and we will certainly end on time. We do open the question and answer tab to the audience. If you're watching live, you can click the Q&A at the bottom. If you put in a question that is of general interest and not 5 minutes before the show ends, I'll do my best to try to weave it into the conversation. I can't make any promises, but I do like bringing in the topics of interest to our audience. The chat function is disabled, so please use Q&A. As with all of our events, this is being recorded. It'll be posted to our website within just a couple of days. If you enjoy this event, please share it with others and point them to the website to watch it as well. So without any further ado, let me introduce this incredible collection of talented public servants. I'll start with the current occupant of the chair, Mickey Tripathi, the current National Coordinator for Health Information Technology, previously the Chief Alliance Officer for Arcadia and a project manager of the Argonaut project. And then I'm going to reverse course and go from earlier to later. We'll start with David Brailer, the first national coordinator, who's currently the Chief Health Officer at Cigna Group and Vice Chairman of the Duke Margolis Health Policy Center, followed by Rob Kolodner, who is now the Vice President and Chief Medical Officer at VitalNet. We then pick up David Blumenthal, who is the former president of the Commonwealth Fund and a professor of the practice of public health and health policy in the Department of Health Policy and Management at Harvard's T.H. Chan School of Public Health. Karen DeSalvo is the Chief Health Officer at Google, and Don Rucker is the Chief Strategy Officer at One Up Health. We have managed to get everyone other than Farzad on the program today, so we're really excited to have this depth of expertise. So I'm not going to offer a long introduction because we're going to cover really what ONC does and how that has evolved. I'm inclined to just sort of jump into letting you all tell the story, the creation story, the early evolution story, and how we got here today. And I thought it would be best to do this with a sort of a passing the baton from each of you to the next. So if you could just start with, what did you see as you come in? What was the charge to you as you walked in the door? And what then did you feel that you handed off to your successor? I'll ask you to answer that question in just a couple of minutes. We'll go much deeper into all of these things, but I think it's the best way to introduce the audience to the evolving role of the office. So David, I think I need to start with you.
Okay, well, thanks, Alan. I appreciate it. And it's good to be with my colleagues here and to talk about something that's near and dear and important to all of us. So your question, what did we see as challenges and what did we pass on? My answer to both questions is everything. As the first, everything was a challenge, and I passed mostly everything on to other people to do. The more refined answer is, when I came in, I think we had certain assets that were to the advantage of the health IT movement. There were three things, really. One was clearly, from the moment this was announced, very deep support in the industry. Kind of the time had come and people recognized it, and that created enormous amounts of thrust that pushed it past many other competing programs in the health space. Two, we had strong presidential support. The president was, many people were shocked at the level to which he was personally very invested in this and wanted to see it happen. And there's a whole backstory of that I won't share, but there's a lot going on. But in the end, that was the second one. And thirdly, we really had the capacity to, the technological readiness, perhaps, to make this real. The movement had obviously been going on for 30 years before that time, but it just wasn't quite feasible. And the internet era and the other pieces that we all know about really kind of stacked up to do that. We had one other catalyst I would mention since we're on the health affairs video conference, which is we had the enormous support of John Aglehart, Alan's predecessor, who had written extensively about health information exchange and clinical data and had covered the work we did in Santa Barbara, where I am today, oddly enough, had covered that work. And many people that I talked to on the Hill or in the administration or in the industry were widely aware of his writings. And that really helped, I think, prime the pump. The challenges were nobody really wanted to talk about this. There were other competing health goals. The Bush administration had stood up MA and Medicare, well, Medicare Part C and D, enormous issues and challenges. Republicans thought of what we were doing as industry manipulation. So this was, industrial policy, and we're not supposed to do that. So, were a lot of challenges, but I think the biggest one was we didn't know where to start. We were creating an agency, creating a strategy, creating kind of a capacity to move forward. And I think the positivity that we passed on to Rob was that there was a strategic framework that at least laid out the basics that got people all using similar language and kind of thinking about this categories. And, we passed on momentum and at least a core staff that could begin operating against the goals and keep growing. So I would say that were the good things we passed on. And then everything else we passed on for Rob and successors to do. And I just am very, very happy that they followed the strategy that we laid out and did their job quite well. So it's, because we made it easy for them. No, it's really been, something that we've all worked on together, and it's shifted and turned over time. And yet I think some of the cores remain the same. So I'll leave it there and we can go further at the right time.
That's great. Thank you. So Rob, is that what you walked into, and what'd you hand off?
So David recruited me to come over, and I turned him down twice before finally accepting the request to meet with Secretary Leavitt, knowing that there was no way I could say no to the secretary if he asked me to come over. What I didn't realize at the time was what my biggest challenge was, and that was, unlike any of the rest of the national coordinators, I came from another agency. I came from within the government. And that meant that I wasn't part of the political group that was in the White House. It meant also that Secretary Leavitt had to advocate for me being selected as the next national coordinator for 7 months before the White House would stop trying to put in people from the outside to move in for a year and a half or so, most of whom did not have the background in health IT, but would have been political appointees. So when I finally, when the White House finally said, okay, we've got, we don't have enough time to bring somebody else in, and recruited me over after agreeing to not talk about the wars in Iraq and Afghanistan before being offered the job, which was nothing that I particularly wanted to talk about. I was able to come over, but I also was naive enough to negotiate that the position would move from being a political one to being a career one, which it was made, and I was put into that career one without understanding that it wouldn't mean anything anyhow with the next administration. The other part that it meant is that I was one level away, that I was not brought over to meet with Congress. I was not brought over to meet with the White House. There was a political level that was above. The advantage I had is that the secretary was very much behind this. He chaired the advisory committee, which is very unusual for him to do, a SMAG. So there was strong support for it, but I was basically there to execute something as opposed to it being integrated with a wider health policy that was part of the administration. in that regard, because because of the position I had, what I was able to focus on was making real some of the things that David had put together as aspirations, including not only getting a strategic plan approved through all the agencies and working with all of the agencies for that, and engaging those agencies in that plan and in moving it forward. The only levers we had, because at a $60 billion budget, there wasn't a whole lot of levers, it was looking, at least the strategy we had was, could we use the budgets of those different agencies as attractors, having veterans and DoD retirees embedded in the private sector and putting into those contracts things that would require exchange of information and gradual adoption of the standards. But it's lightweight types of levers, but using the government levers. And because I had been in government, that was the strength that I could bring at the time. The challenges that I left were many. We did a demonstration of what was then the NIN, the nationwide, not national, health information network, and some lightweight preliminary standards, but a lot of work left. However, passing it to David was easy because he came in with high tech.
Perfect handoff. David.
So it's great to be with my colleagues here and great to be with you, Alan. I guess I was the proverbial dog that caught the bus. But I hadn't really been chasing the bus. But the bus caught up with me. I was not an IT person, as my colleagues here know. I'd written a few things about it thanks to David Brailer, who had offered me the chance to do some studies of IT. But I had worked in the Obama campaign, and when the huge then huge, now not huge at all, $800 million financial rescue plan passed, it included this high-tech thing. The White House wanted someone to run it who had worked, as I had, on the campaign. And so I also was offered the job twice and refused. But eventually it was clear that that not only was it the best job I was likely to be offered, but also it was a pretty interesting job. So what was our challenge? It was to create in 9 months the meaningful use concept, the meaningful use regulation, a process for certifying electronic health records, and the standards against which they would be certified. You all know, or sophisticated people know, it takes 18 months roughly to write a regulation. And I had these 3 to fashion out of whole cloth. Plus, and this is where a gift sometimes can be more than a gift, I had $2 billion in discretionary funds that had to lay the groundwork for the implementation of the regulations that would begin 9 months hence. And that meant making it possible for doctors and hospitals around the United States to effectively adopt and meaningfully use electronic health records. That pretty much fully absorbed me for the 9 months, and my staff, and Farzad Mostashari, who's not here today, was absolutely critical to making this possible, as were some of the folks that Rob and David had hired. But the other challenge I had was that without any funding, they had a very small office that hadn't been writing regulations or giving out massive amounts of money. So I had to create a new version of the Office of the National Coordinator that was capable of spending money without getting me into an orange jumpsuit, and spending it effectively and getting the regulations written with CMS, which was our partner in the meaningful use regulation. So it was a pretty exciting time. And we can talk later about how it all worked out. But the one thing, I think the biggest challenge I passed on to my successor, Farzad, was that neither he nor I could figure out exactly how to solve the interoperability problem. And we're not the only ones who've had that problem. we had to spend most of that money because if we didn't spend it, Congress was going to take it back. So success was making sure there was no money left over when Farzad took over.
Well, we're going to leapfrog over Farzad Mostashari, who could not join us today. But David, you've explained, I think, a little what you handed off to him, and he was there with you for your tenure. Karen, you're next up after Farzad.
Well, great. Thank you for getting everyone together. It's always nice to see these faces and be a part of this ongoing conversation. I think one of the beautiful things about the Office of the National Coordinator is that it has so much continuity from coordinator to coordinator. We do work together really well as we're doing the handoffs. Like many other people who became national coordinator, I did it reluctantly, but also then began to realize the tremendous opportunity, especially as it aligned with other ongoing goals that the then administration had and that the country was leaning in towards, in particular, thinking about the importance of moving to outcomes-based care instead of reactive fee-for-service care, and how important data and technology was going to be in order to make that advancement. And so we were thinking a lot about increasingly pairing up the work that was happening in CMS around value-based care and how we were going to use this digitization of the care experience to be able to understand improvements in quality and safety and outcomes. But I'd say the biggest thing that I picked up from Farzad was also in the sphere of change management that David Blumenthal just described. I came in from the cliff of the funding at the time when we had a dramatic reduction in the budget and we needed to change ONC away from being a grant-making organization and then back to a convener of stature, both within the government and within the ecosystem. And thank goodness for some of the tremendous talent at ONC who are career government folks who have been there since the time of David Brailer, who understood that kind of a role when they worked with he and Rob Kolodner, and had then been through the systemic change. And many of them have then stayed through as we transitioned to understanding how we needed to use our role there to set strategy for the U.S. government. It's one of the responsibilities of the Office of National Coordinators to set the Health IT strategic plan. We built that around the consumer. We strengthened our relationships with other government agencies, very much following a playbook from Levitt's time, honestly, Secretary Levitt, of how do we think about the whole of government moving together to help partner with the private sector and do this in a very partnership way with the private sector. I think one of the other things that was on my plate was to harmonize standards, because we had so quickly had to stand up the digital ecosystem that whatever standards were in hand for the electronic health records companies were basically what were implemented. And so we had this real difficulty in systems communicating. So moving towards creating a shared understanding of what's now become essentially the US CDI, what are the ways we'll think about harmonized standards and start to move to those that are non-proprietary, especially moving in the direction of FHIR. So beginning to lay the foundation for interoperability. You know, when the time came to hand it over to Vendel Washington, who had been my deputy, and then when I stepped out towards the end of the administration, he stepped in to lead. He was able to pull across the line some really important work that we were doing to ensure that the Office of the National Coordinator had the right authorities and approach given to them by Congress to be able to create interoperability, to have the authorities to do and drive that, and also around open standards like FHIR, particularly a use case for them for creating APIs so that consumers would have access to their data in a way that would allow it to be an ecosystem where they had that kind of information and insights, and it wasn't just sitting inside of the data that was inside the healthcare systems. And so Vendel couldn't join us, but I just want to shout out how great he was at those bipartisan discussions and sort of then teeing it up so that we could have this next chapter that Don should be really proud of how they carried forward. So maybe with that, I'll hand it to Don.
Thank you. Before I let you hand it to Don, I just you're in an acronym filled field, ONCHIT, but if you could just remind our audience what FHIR is, I think that would
Yes.
probably benefit those who don't.
Of course, FHIR is Fast Healthcare Interoperability Resource, and it is an open standard, which means it was created in a way that everyone can see the code essentially and could make use of it, so that it would enable more appropriate but free flowing of information. So with consent and privacy and security built in, but you didn't have to get permission to learn other standards. And it's also a better, smarter, faster, cheaper way of not only packaging, but also sharing information across systems or within systems. And it has a fellow named Graham Grieve developed it. He was the champion for it, a fellow from Australia. But there's a whole group that helped to spur it up called the Argonauts. So it is it has a community of owners, which actually has made it even more useful because it's not one company, but FHIR has become the emerging standard for all of the healthcare sector.
Thanks. Just want to keep
And
us all
public
on
health.
the same page.
And now public health as well.
Great. Okay, sorry, Don, I jumped in before you got to go, but take it from there. Oh, Don, you're on mute. Gotta come off.
Yeah, spelling out acronyms is always a challenge in this field. Yeah, I think I was obviously lucky in a couple of ways from the cumulative work that we've just heard about. I guess the particular piece of, I don't know, luck I had there, I think there were actually two pieces as I look on what we were able to accomplish. One is a great ONC staff. And, I don't think that's like a given. You've heard from everyone how, they sort of formed that. That's not a given. And when you get down to writing complex regulations, that is absolutely critical because, I think the real issue with interoperability is mostly that we have massive incentives not to operate. I mean, the dominant incentive in American healthcare is for delivery systems to consolidate, look inward, use inward-looking EHRs, and only share if they're absolutely made to. Is that the right way? No. Is that the way it would be in a market economy? No. But, it's American healthcare today. The other big piece of luck, thanks to Karen and Vindel and members of Congress, and I'm not sure where the plot it should all lie, but many of them was the section on standards-based APIs without special effort is the provision in the Cures Act that basically allowed us to write a series of rules to make the FHIR APIs real, to expose all of the information that was now sitting in the EHRs and actually expose that and put in the control of the public in a usable way, which I think is the way of the modern digital universe. Just in healthcare, it hasn't been. And I think the challenge there, it was clear to me from the get-go that this was going to be a massive sales pitch, right? Talk after talk, meeting after meeting. I mean, literally hundreds of both to sell that vision and make it robust. So at the end of the 4 years, people sort of accept it as a given rather than as something that would be really good to lobby against on Capitol Hill. Now there's still lobbying against some of this, as there was before, but that I think was really a wonderful opportunity, and hopefully will be a great step in bringing healthcare computing, which, as we know, has really lagged the rest of the software world, to sort of catch up over time.
Great, thank you. That's a nice handoff over, Mickey, to you to tell us what you walked into, and you can't tell us yet what challenges you're leaving your successor. You can talk about what you're tackling right now.
Okay, great. Well, thank you, Alan and Health Affairs for the opportunity to be here. And and thank you to all my colleagues. I will say, overall, I'm just really grateful that the assets that all of them put into place have compounded at a much higher rate than the liabilities. So thank you for that. I came in with net positive assets, so that's good. I guess just to mention a few things in terms of the challenges taking on the job. One, came in the middle of the pandemic. The pandemic was still sort of very hot, and that was a challenge across the government. We had to do a lot of work on preparedness that afforded a lot of work that was happening that was sort of outside the normal channels than one would normally find, as you think about things that the Congress had passed that sort of suspended certain rules related to information sharing in certain ways, or a whole bunch of things like that. A lot of work directly with the White House as we're working on preparedness as well. So that was certainly one set of challenges, was just getting over the pandemic, putting us in a better place as a country to be able to emerge from that successfully. The second set of challenges was that as excited, enthusiastic we and I were for the 21st Century Cures Act, none of it had been implemented when I came in. And obviously, the pandemic was in the middle of that, right? So there were a number of delays associated with that as well, and then the regular rulemaking delays and and all of that, but none of that was implemented. So that we needed to put that in place and get that going as well. Which was a second set of things, and that was everything related to the information blocking rules, the rules related to appropriate disincentives, which we had to kind of start from scratch, and then TEFCA. So that was a second set of things, and then finally, I would say and this is a little bit more of a bigger meta challenge, but more of an opportunity as I see it than a challenge, which is that kind of turning the corner. For those who know the Gartner hype cycle, kind of emerging from the trough of disillusionment to sort of being able to now be in a position where we say, what, a lot of the hard work of getting a foundation of electronic health records is in place. We can now turn that corner to start to say, what are the opportunities that we want to be able to have, that learning health system that Karen was describing. And then, of course, the intersection now with AI and the opportunities that sort of affords all of us, I think are a challenge because you need to kind of work hard with an industry that has thought of electronic health records in the context of clinician burden, but being able to turn that corner to talk about the opportunities, the real opportunities that are here. And I think there's a lot of light on the horizon that I'm really excited about.
Great. Well, thank you all for just sort of giving our audience a sense of the evolution. I've got some great questions from the audience, but you all said some things that I want to follow up on before I try to bring them in. One has to do with the policy context. David Brailer, when you started, you mentioned Part C and D, and Karen, you mentioned pay for performance and the infrastructure. I'm very interested in the degree to which during your tenure you felt that you had sort of a technical challenge in front of you, or you had a policy challenge that you were contributing to addressing, or maybe there's a third option, and I'm sure it's some of each. But I'd love to get some sense of the context of how your work fit, how it felt to you that it fit, or maybe how you felt it didn't necessarily fit with a broader health policy agenda. Who wants to say a little more about that? As I say, a few of you introduced that subject. David.
I would love to jump in because I arrived with a president who may be the last Democratic president who feels like he or she has to remake the healthcare system. And that was the president's goal through the Affordable Care Act. And delivery system reform was very much a part of his agenda and his staff's. And they well understood that information was critical to their effective cost control agenda and their delivery system reform agenda. So I always thought that healthcare reform, as the president conceived it, could not succeed unless our work succeeded. I also felt that our work could not succeed unless the larger agenda was established for the reasons that Don pointed out, which is that our healthcare system was configured in a way that made the use of health information actually perilous for providers of care, and militated against the kinds of information flows that would make health reform possible. So from the very beginning, I saw us walking arm in arm with what the White House and the Secretary wanted to accomplish.
Very clear.
Maybe
Yeah,
I'd love
I
to
would. Oh, go
I
ahead,
just
Karen.
Karen.
want to pick up on that because I was on the receiving end of David's grant making when I was in Louisiana, and we had all three of the high-tech grants. We had the Beacon grant for using the data to improve community outcomes, regional extension centers, and the Health Information Exchange. We were, I think, one of two states that had all three. Rhode Island might have been the other. And I think what we were experiencing was a lot of energy around the implementation of electronic health records. So the support on the front lines, desperately wanted and needed and helpful to the clinicians. I think the other two efforts from a pacing standpoint were ahead of where the data was. And David, you all were doing what you needed to do because you had to push the money out. It certainly helped create a lot of community conversation about what a future can look like. And we began to build business bridges and sets of principles and ways of working and organizational structure that would later allow for more data cooperation, if you will, and interoperability. But I think this was a nut that when I then came into government, it was a thing I saw on that end and heard from a lot of providers that even if they wanted to use this data to change practice, to focus on outcomes, to think about different ways of delivering and financing care, mostly there was data going into a system, but it wasn't coming back. They weren't really, because it wasn't robust enough. It just wasn't rich enough to be able to really do the analytics to inform the kinds of decisions that provider and payer organizations needed to make. And I think fast forward to today, that's changed dramatically because now, the healthcare system does have the ability to have that kind of a dashboard, but we were so early in implementing technology that I think we were just a little bit ahead of what we were trying to do for that broader value-based care or health reform movement. And I hope that the pacing now gets a little more aligned and that AI, frankly, can help accelerate some of that work. But we were certainly on the same path when I got there in the second term of how do we think about this as an opportunity to have evidence-based decision-making for providers and for others in the system. I think it was just a little harder to kind of get there wasn't quite as much richness of the data yet. And I think we've made that evolution.
Yeah, if I could jump in, I think that there was sort of a couple big speed bumps that to get all this stuff to sort of work on the trajectory that all of us really want, and some of them I think came from the providers were sort of a little bit upset by the lack of usability of their systems, frankly. And maybe as somebody who's been a provider all my career as well, a little bit upset's probably an understatement. Now, they sort of see it as a black box. The computer doesn't like me. I don't think the computers have that much in feelings. But a lot of it ultimately goes back to the 1995 billing rules, which were the CPT coding rules, which were an attempt to mitigate, I guess, fraud when you get right down to it, or soft fraud. And the combination of what IT enabled with building all of these charts with totally fake data, right? These 10 organ review systems and 8 organ physical exams where nobody looked at it, meant that almost every advanced note, level 4 and level 5 notes, had this sort of undertone of, I won't call it fraud, but let's call it clinical goofiness to be, there. And part of, I don't know if this was by plan, Karen, you can tell me, but there was a provision in the Cures Act that CMS and ONC should think about EHR usability. And we used that, so we being SEMA and myself, to basically force the AMA, frankly, over their resistance, to get rid of all of this sort of goofy documentation. So what we're talking about are the level 4 and level 5 CPT codes. So I think that as that fades in the past, I think we've reduced the whole friction, increased the whole productivity of EHRs and the data in there, whether it's for AI or population health or equity or whatever use you'd like. By doing that, I think the other thing that was clear, there was one final missing piece that Ken Mantle at Boston Children's sort of pointed out to me, which was we didn't, in all of this work, right, from all of us collectively, we hadn't really enabled looking at population health in a seamless computational way. So part of what we did when we, wrote and implemented the Cures Act rule was put in the bulk FHIR APIs. Now that's early, but they're really taking off. And that's an effort which I think will be of great interest to health affairs audience to actually have a computational API to get at the data. Now the US core data only, but that's a vast set of data to actually start using everything that ONC has built over the last 20 years in a way that's going to help populations as well, separate almost from some of the individual consumer choice things. So I think part of what the agency has done, right, maybe that's in the sea of coordination, are some of these really subtle but profound mechanical things that have moved the whole scrum across. The reality of time, hopefully those things will be, oh, was it ever different? I talked with somebody who's just finished residency, didn't know what a 10-organ review of systems was. So, and that means we've done our job.
David Brailer, you have been trying to get in.
Well, no, it's good. I'm glad hearing these stories. By the way, I think I'm the only national coordinator. We'll let Mickey be a sphinx on this, but I think I'm the only one that actually wanted the job, it sounds like. But two comments to your question about the intersections with policy. With respect to the healthcare market, this was pure vision. If we don't have health information organized and available, we will not achieve market efficiency, price efficiency, transparency, consumer choice, all the goals that we all sought. And so this was all a presidential inspiration and vision to say, let's get this moving. This is going to take a long time, but if we don't start now, we're not going to get there. And by the way, it was very clear in our debates, and this comes back to the name of the entity or the name of the movement. It was not about the technology, it was about the data. And we almost called it the health information as opposed to health information technology. And there was a very large debate in the administration about what to call it because people didn't want it to be about technology. But I think what people miss, and this is frankly how I came across Rob and people like Robert Woff from the DoD, my principal job from day one was to assess, inventory, and bring together in a coordinated fashion, hence the term coordinator, all the various agencies, which numbered more than 45 agencies that had either funding or authority, or more importantly to them, perhaps the premise of authority over some aspect of health information technology, standards, data, access, budget, vendor specifications, and pulling that together so we had a one government approach and we could understand what DoD was doing, what VA was doing, what the Indian Health Service was doing, the Department of Energy, the Department of Labor, NLM, NIH, CDC. That was the principal job, and we spent more than 2/3 of our time on bringing together the agencies into a more coherent message and approach going forward. Way more time on that than we did on the external part.
I appreciate hearing the variety of policy goals ranging from completely transforming the healthcare system to supporting an agenda of transparency and also disrupting sort of some of the practices within the system. So I hear a fairly consistent message of feeling that you were a part of something bigger. Mickey, I'd be remiss if I know you and I had a one-on-one, and probably half our audience here heard you talk about that, but since you are the current occupant of the seat, probably be good for you to spend just a couple of minutes telling us where you see your current work fitting within the administration's agenda.
Yeah, where to begin and where to end, I guess is probably the the bigger part of it.
I'll let you know about that part.
Okay. So a few things just to reflect on for a second. Maybe just starting with sort of an example. I just today and yesterday, I'm not there today, but I was there yesterday. We've got a cancer data summit going on that is co-sponsored by ONC, the National Cancer Institute, and the White House Cancer Moonshot Team. And there's about 200 people right now out at NCI headquarters in Rockville in Shady Grove, rolling up their sleeves, building the cancer data model to support diagnostics, research, and in the near term, support the CMMI enhanced oncology model data elements to support the launch of that model, which is in September of this year. And the reason I mention that story is that there are like 200 people there. It's vendors, researchers, multiple agencies, FDA, CDC, NIH, ONC, CMS are all out there. You've got, I think I said multiple vendors, provider organizations, all of them working together, rolling up their sleeves, literally going through data elements. And importantly, all of it is to support the data model that they're working on is the US CDI Plus for cancer. And the US CDI Plus for cancer, I know it seems like a weird alphabet soup. Let me just describe that for a second, because what we've done is recognized now. I think there's increasing, and actually it's not even increasing. I mean, well, I guess it's increasing, but it's already fully instantiated recognition across our federal agency partners of the foundational importance of health IT and data standards and information to their mission objectives in a really deep way. And a lot of that, again, is because of all of the work of my predecessors, my colleagues here, of getting that foundation built. So now we're at a point where there isn't an HHS agency that doesn't see as a core part of their mission the ability to tap into and try to leverage the electronic health record base that has now been put in place and the interoperability base that's now been put into place. And so we've kind of turned the corner to say that we, ONC, need to be working proactively with each of those agency partners to say, how are we going to make the best use of health information technology to support your needs? And one of the critical aspects of that is that US CDI, that core that Karen had mentioned, the US Core Data for Interoperability, which is that minimum data set now that's required to be supported by electronic health record vendors that cover 97% of hospitals, over 80% of ambulatory providers, and is increasingly now the core data set that all our agencies are starting with. So just to give an example, US CDI Plus for cancer is saying, and this is the researchers, NIH, FDA, saying that going forward, the cancer data model should not be a separate and unique cancer data model built by researchers. The cancer model of the future starts with the US CDI. And we build the additional data elements on top of that to extend what's already available across the healthcare delivery system, right? That may seem like a small thing. That is a huge change in terms of our sort of the conception of how this ought to work, which is a recognition of saying that foundation's in place. Let's build for that, rather than every one of us sort of saying, all right, what's my ideal world? And let me just build that over here in this silo, right? It's all now sort of tying together. So we have a US CDI Plus initiative for cancer. We have a US CDI Plus for behavioral health, which we just launched. US CDI Plus for public health, which we're working with the CDC and the jurisdictions on to have a public health data model. A US CDI Plus effort for maternal health, which is an administration priority, and a US CDI Plus effort for quality. The last one I'll mention is a US CDI Plus initiative for UDS reporting from HRSA. We often mistakenly think of federally qualified health centers as being behind. It turns out that HRSA has put into effect a full FHIR-based reporting mechanism for UDS reporting that's now in production. We worked with them on building a FHIR server for them to receive that. And that's based on the US CDI. Again, we worked with them on saying, what's the existing UDS reporting? How do we tie that to the US CDI and then add the additional data elements that you need for UDS, and they call it UDS Plus. And then we worked with EHR vendors and got them to commit to implementing that and putting that into production. That went into production on January 1st this year. So that's a lot of the work that we're doing in terms of, sort of the policy objectives are to serve the missions of our agency partners and do everything we can. The secretary has put into place a policy, last point, that with ONC to require that these agencies now base all of their things on ONC approved standards, which I think, kind of seals the deal to sort of say, all right, that is how we make sure that the technology is tied to policy objectives.
So I'm so glad you answered this question, because we do have a tendency to speak about these roles and functions at a fairly high level. And by taking us into what it really means to make this happen is another type of insight into the work that I think is critical. So I have one more sort of foundational question, and then I've got so many specific questions, many of which have come in from the audience. But I do just want to ask, I'm sort of going to lump about 3 different questions together. You all seem like you get along pretty well, at least on camera. And I'm not sure if I brought, half a dozen former exes, fill in the blank, for some agencies that you would see that. I'm also struck, as you introduced yourselves, that each of you talked about what you brought, and a number of you acknowledged the things you didn't bring to the table. And so I sort of want to piece these together and just ask at a foundational level, sort of how you think about the strengths you were able to bring from your own experience, but also how you thought about making sure that the domains of the work that are essential for success that you didn't bring were present so that you could be effective. And it's, a few of you mentioned this at the outset, but it was such a consistent thread. I want to pull it and hear a little bit more about it. Whoever wants to go first, I'll let anyone answer that.
Well, I will jump in. So I freely admit that I am not a computer person. As a matter of fact, wherever I went while I was national coordinator, I would start by saying that my wife takes care of the computers at home. And I think that made my audience a lot more comfortable, and it is true. But what I did have was experience using electronic health records as a clinician, and experience as a hospital manager, and deep experience with healthcare policy generally, and with an understanding of how government works. I believe that most technology issues are about people, not about technology, and that this field, though all of us get along despite what might be basic philosophical differences, because we're sort of united by the technology. In fact, I think we might have very different views of how the system ought to be fashioned. My sense has always been that it's those underlying values and approaches to how the system should work that determines whether technology is adopted and effectively used. So it's always about the people. It's always about convincing people. My job was to sell the adoption of electronic health records. Mickey's is to sell, or Don's was to sell interoperability. David was to sell an administration on the very idea that electronic health records and technology and information were important. But there's an enormous amount of convincing of people that goes on. And I think my experience, having used the technology and having been in the role of those clinicians and hospital managers we had to turn around, that was the most valuable asset I had. That plus simply an understanding of what OMB did, which, if I listened to the people who briefed me when I came in, that would have been a huge mistake, because I don't think they understood it. So I'll stop there.
I can jump in. I think David's definitely right that it's the technology is just a tool for people, and so how people accept, adopt, understand, use it for good or for other purposes. They have to be. You have to understand the workflows. You have to understand what are the priorities, and what is it really like on the other side. And like David, I was not a technologist, but I had applied, especially technology and electronic health records, in healthcare systems that I ran, in policy work that I was doing in public health, because when I came to the Office of National Coordinator from being, at the time I was the health commissioner for the city of New Orleans. So public health and social determinants of health and community health were very much on my mind, and how is this information going to help advance that agenda in addition to the agenda of transforming the healthcare system. I think the thing about the Office of the National Coordinator is that it is a job of convening. You're a coordinator, you're influencing, and that to me means you have to come with the humility to listen and to understand perspectives. It's helpful if you have your own experiences with it. And I think you have to also think about how to move the levers of government in unison, and not think of only doing it through rulemaking or through discretionary funding. And I think a lot of us did that in many different ways. But one of the things I loved about what I learned when I got into the office was, first of all, this history of how David and Rob and Secretary Leavitt had really thought about the importance of convening whole of government, of then working with the private sector to make change in that way, being very outcome oriented. I loved that a lot of the people who wrote the original thinking about the Office of the National Coordinator were from the CDC. They were public health people. And so they were, if you see a lot of threads in that of thinking about population health and health outcomes, the Beacon grant that David Blumenthal put in place was about population health and public health. There's a lot of threads that I think give a lot of, I'm at Google, so I'll say that widen the aperture of beyond the healthcare system. And I think with each successive turn of the Office of National Coordinator, we've also, I think, done a service to the health of the people of this country, of thinking it's not about the technology only. It's not about just electronic health records. It's not just about healthcare, but what are the other ways that we need to think about advancing health, whether that's better science, better care, better public health, and better addressing the social determinants of health. But if you go all the way back to the beginning, the themes run there, and we've just been adding the modules as time goes on.
I could add, I think I brought maybe a little bit of a different thing in sort of having formal computer science training, if that's the right thing to do after residency, I don't know, but it's been fun, certainly an amazing ride. And then literally spending 30 years as an EHR vendor. So, and getting people to use the systems for things like computerized physician order entry. Thanks to David Blumenthal for putting a big push into that set of sales. But getting people to use this, so it makes you more appreciative of things like the U.S. core data set, which we were able, it was developed by Karen and Vendel, and then we put into the first version, and Mickey's worked on it, as he just outlined nicely. Since then, I had done a lot of lobbying for Siemens on the outside in lobbying, which, at a fairly sort of big dollar, fairly sophisticated DC law firm. I don't think that really prepared me from the inside out, and the whole coordination of agencies, even skipping the OMB, beaver dam at the end of rulemaking, even skipping that. There, I was honestly helped by frankly, folks at the White House. So Chris Liddell, Jared Kushner, Eric Hargan, and Will Brady at the HHS. So I think that for me was a learning, and it's one of the core pieces. I think most of the other folks probably had a bit more of that than I did. The ONC staff, Steve, I don't want to name them all, Steve, but Elise, Beth Myers. I mean, they were, Lisa Lewis Pearson. I mean, they were just stars in getting that through these complicated things and sort of making some more of the whole. Sounds like David Brailer sort of had that nailed from the start, but for me, it was a bit more of a learning experience. But there are a lot of pieces, and I think we've all discovered the pieces we didn't have, is what I'm hearing here, and put them in as well.
And Alan, I think one of the things is that the advancement of the need for for a coherent infrastructure to both cut the costs from a business point of view, to have that information flow to help the individual patients get better care. That's something that had bipartisan support. So while the different administrations may have different philosophies about how you do it, the goal was a shared one across all of us, and each of us brought different strengths. It was clear that we would need that because there was going to be an evolution, and when there was no movement, what we needed was a cheerleader, had the power like David Brailer did to get things started. And each of us then contributed as things evolved with what was needed then to move it to the next stage. And so we did feel like a team, even though we crossed administrations, crossed philosophies of how to do it, that goal, that shared goal was, I think, very much the same.
Well, I have a long list of questions from the audience, and I'm not going to ask all of you to respond to all of them because we don't possibly have time, but I'm going to run through some of them fairly quickly, including some that have fairly strong points of view that you should hear. Let me start with, actually, this person has two questions, but they both have the same tone. Electronic health records have increased cost and not been shown to improve care. Have helped to close 20% of small rural hospitals and hurt rural health care. Did it have to be this way is sort of the question. And I'd love to hear how some of you react to that set of questions and comments. Sure, it's not the first time you've heard it.
I'll take that one. That probably has been a consistent theme. I think in all of this discussion, of course, this plays to what health affairs has been all about. You have to separate what we're talking about. Let's just, for self-referential sake, call it the foreground from the background of economic incentives in healthcare, right? ONC ultimately, and even health IT policy, is a very small part of the payment macrocosm. And I think when you look at, who's been displaced, what's happened, you really, before you come to ONC and IT, I think you have to look at what are the big incentives. Went to your original thing about interoperability. Well, Congress can put in rules, information blocking that says you shall not information block. But if we're paying people, if the whole margin of the delivery system is in collecting referrals to high margin procedures, stinting on primary care and prevention, that dominates anything that, IT has to do. So I would encourage your listener or questioner to think about that broader picture.
Yeah, I'll make a quick comment first about rural hospitals, having been born in one and still supporting the one that I was born in to keep it afloat. I wouldn't put health IT on top, even on the list of the top 10 things that are stressing rural hospitals or rural healthcare. We've not had adequate rural healthcare policy for a long time in the United States. We have enormous forces that are working against rural healthcare. I think one of the biggest equity issues we talk a lot about all the other equity issues, is rural versus urban care. So it's a terrible problem. Don't blame health IT for that. More importantly, to the question of has it added value, I'm not sure that health information technology has added value. I'm certain that health information has added value across research, across public health. I'll give you an example that we don't have to go to recent for. The catalyzing event for health IT, in my opinion, where I finally got past everybody that didn't get what was happening, was during Hurricane Katrina, where we stood up Katrina Health with the Markle Foundation. And that pulled together the records of all the electronic prescriptions for all the people in the affected areas, so people in the shelters could try to have continuity of therapy and understand what was happening with people. And I think Karen was involved with that to some degree back then too. Another tie amidst the coordinators. And that's just one of, I think, countless examples that don't make the headlines. That one did make the headlines, but that don't make the headlines every day, where the use of health information in an emergency room, in an urgent setting, when people are transferring care or moving or migrating through care services or many other things, I think are countless, and they are piling on each other and getting stronger over time.
So I think one of the biggest problems we've had with health IT is its lack of usability. And I think it was Don who talked about the CPT code coding issue. And the records that we had when high tech was passed were designed to maximize revenue, not to, and that is so emblematic of the forces that shape our healthcare system, which are now, in my view, completely out of control. The maximization of revenue through increased prices, consolidation, you name it. They seeped into the IT industry, and that's because that's what the industry wanted. It's not because it was what the vendors conceived of as the right way to do it. But CFOs were the ultimate arbiter of adoption, and they did not want ever to get in the way of revenue collection. As a matter of fact, they wanted to maximize it. So that's what we had to work with. When I was at the office, national coordinator, we went out to NIST, the National Institute of Standards and Technology, because we wanted to develop standards for usability. And we had a long session with them where we said, well, what's the science of usability? Is there a way we can create incentives or define it so that it could be rewarded? And they said, we don't have a science. There are no standards for usability. We can't regulate on that. It wouldn't withstand legal scrutiny. That is a basic issue in the developmental state of the health IT and IT generally. I will say that there is a next generation, which I see every day because my kids are physicians, for whom this technology is not alien. As a matter of fact, it is essential to their daily work. So I do think there is a evolution going on in people's utilization of these technologies. It's not that the burden is going away. We would not be able to have an AI industry in healthcare if it weren't for the electronic health record. I mean, healthcare would be simply left behind. None of the benefits that we now are anticipating from artificial intelligence and the risk would have been inconceivable if it weren't for David Brailer, Rob, and all the folks who conceived of and started this movement. So I just think you have to keep your eye on the future.
I completely agree. I was going to say, I completely agree with that. I think that some of the that it's certainly fair to question at all times and continuously whether we're getting the return on investment for all of the public and private investments that we've made. But I think that we're starting to see, I mean, there's an old adage in technology that we always overestimate the benefits in 5 years and we underestimate the benefits in 10 that we're going to get in 10 years. And I think we're actually living that now. I think we're actually living that now. And you start to see even, I mean, I think Dave Blumenbach made a tremendous point that we are so well poised, especially compared to our industrialized peers, to be able to leverage AI in really powerful ways, in ways that are the envy of most countries around the world in healthcare. That is building on that foundation that we've you lay these investments and they pay off over time. I would even argue, if you look back, and the pandemic has not been seen as a wild success by any stretch of the imagination of our healthcare delivery or public health systems. But I would point out that the things that we were able to do, like pivot an entire population to still being able to get care via telehealth, wouldn't have been possible at all if we didn't have that foundation of electronic health records in place, integrated electronic health record with the capability to plug in telehealth in very rapid fashion to be able to still continue to provide care in a manner that again we would have never been able to do. The information that we're able to get on vaccinations, for example, albeit imperfect and spotty and improved dramatically over time, that came from certified electronic health records using HL7V2 interfaces, pumping out data to immunization registries that we were ultimately and now are able to leverage in important ways. So I think that the questioner actually is I mean, I question some of the facts. I don't think that we should take those as a given. I also think that that there is a dramatic underappreciation of sort of the tide that is rising for all of us because of these investments that have been made, and they're going to pay off over the next 2 years, 3 years, 4 years, 10 years in ways that that we can't even imagine.
Well, I just want to assure you that there are also a bunch of questions in the queue that start with very positive framing, and one of them has so many acronyms I can't read it, but I will say it says what you've accomplished with HL7 and FIRE is amazing. Thank you, ONC, for becoming the Rosetta Stone. So you can carry that that tidbit around as well. So there's obviously a variety of views on this. I do want to ask, Karen, you mentioned public health in your opening comments, not surprising given your background. There are so many directions that I could see expanding out from, and I'd just like to understand your perceptions of them. The move towards greater interest in social determinants, it brings in all sorts of service providers that are not traditional medical offices. Public health, public health infrastructure is in many instances, many respects, distinct from the personal health, the hospitals and doctors' offices that we've talked about. We also have, post-acute. We have the mental health system. There's so many places that are, if we're moving toward population and interest in population health, whether it's through public health or through sort of healthcare or population management, these other systems are important. So what is the thinking here about the boundaries of an effective health information technology infrastructure?
Okay, thank you for teeing all this up. Let me, there was a question in that someone had in the chat actually that I'll sort of start with, which is value-based care hasn't achieved some of the outcomes that we'd like to see. And it was definitely a lesson that was no surprise to me, because we know that some 80% of your health outcomes are unrelated to what happens to you in the healthcare system. They're about where you live, learn, work, and play, your genetics, exposures to racism, other challenges that affect actually biologically the makeup of your body. And so there's a lot more we have to think about to address morbidity and mortality for people and for communities than healthcare. Great healthcare matters, but it's a bigger picture. And we have very little information about what's happening in those other either social support services that you mentioned, or public health often has data that is a rear view mirror look. They're looking at information from 2, 3, 4 years prior when they're trying to make determinations about actions to take to improve mental health or address substance use disorder as examples. And so when you're in the seat of public health, you're doing your best to try to predict forward, but you're very often working on stale information. Whereas healthcare, even though it's only a portion of the population, because not everybody visits healthcare in every year, but it is at least something, and seems to be a pretty good proxy for the population's health. There's some great work that Farzad Mostashari and his team did in New York City, looking at the correlation between information they got from primary care from the New York City Health and Hospital System Public Health, and how that correlates with NHANES, which is a randomized anonymous survey that we do, the CDC does, for populations to understand population health needs. I think it's CDC, you'll correct me, Alan. It is, so we know it's a pretty good proxy, even just to have the healthcare data. It's more real time, and it can inform public health needs for addressing population level action. So all to say that the parts of the health ecosystem that have a lot of accountability, responsibility, and opportunity to improve health, they're not digitized, and they also don't have access to timely, actionable, granular data. That is very much improved in the last few years. We have a very long way to go. I mean, for example, I hope Mickey can talk about this. We're doing a lot more to see that mental health and substance use disorder providers can be a part of the digitization. Long-term post-acute care, there's been more opportunity for digitization. Social services is definitely further behind and requires, I think, some significant funding. We've actually written about this when I was more involved in NASDO, the National Alliance to Impact the Social Determinants of Health. It's nasdo.org, NASDOH. If anyone wants to look, there's some papers there about what are the gaps and needs to tell the more whole picture of people's health and the community's health. Alan, a really key point I want to make here, though, is maybe a couple. One, we often think that for public health action, we need personal health information, and that's not true. A lot of public health actions taken on anonymized population level surveys. So that the timeliness and the action need of the data doesn't have to dip into what we know about people individually in order for us to do good things there. It's not so true in social services like housing providers, but there people can give very clear consent. I think the second thing that I hope we'll all benefit from in this digitization and modernization of public health is the fact that compared to where we were when David Blumenthal was really starting this with high tech, we actually now have a cloud infrastructure that people can rely upon that enhances interoperability between systems. We have more open standards, including FHIR, not the only one, but that is a direction that the public health system wants to go. And so there's a way to build upon those lessons learned. I just want to, if I can, if there's time, hand it to Mickey, because I think he and Rochelle Walensky and others at the CDC, and I'm sure he is working with Mandy now, did a tremendous job during and coming out of the pandemic of talking about public health modernization. They have a great plan. They're already working with organizations, and I think they're making some forward progress. But I do, most importantly for this audience, want folks to understand it's not a nice to have. It's kind of an essential to have if we want to change the trajectory of the life expectancy curve in this country from going down to going up again.
Yeah, let me mention a few things. Thank you, Karen. To Karen's point, and we came in, we were in the middle of the pandemic, and we set as a top priority for us to work directly with the CDC and the jurisdictions on getting us to the next generation public health architecture and infrastructure. And some of the key features of that were one, some of the key principles were integration of the public health system with the healthcare delivery system, because we don't have that right now, right? They're very siloed, and then have these connection points of faxes and phone calls and static HL7, V2 one-way reports. And what we want to be able to do is say that can't be the architecture of the future, and also not scalable, not leveraging, basically commodity cloud technologies that are available all across the ecosystem, being able to do that. So we're doing a whole bunch of that, but let me just give an example of where we are on some of this. We've got the Helios Fire Accelerator, which is working on fire enabling certain use cases, like being able to have a single fire API to be able to access immunization registries. Right? Access to immunization registries was just this unbelievable mind-numbing problem during the pandemic, and just being able to say, why can't we have a single modern specification to just be able to query any of those immunization registries? And there's jurisdictional issues that we have to go through all of that, and we're working on that. But that's one example. The other example that I'll give is TEFCA, Trust Exchange Framework and Common Agreement Network, is now live. We have 4 jurisdictions that are already planning on going live in TEFCA this summer. And we have another 19 that are waiting in the queue. They're actually waiting for us because we can't handle them fast enough to be able to let them use modern network infrastructure to be able to do the type of dynamic interoperability that I think of as interactivity that they're not able to do today using sort of the older standards. And so, but let me just make one just very specific case. One of the use cases that's really exciting the public health community, and that we're doing everything we can to try to put this in their hands, is the ability to just do a simple electronic automated case investigation. Right, so I get a static electronic case report as a CCD, which is, Karen's very familiar with those, others are familiar with those. And then what happens? If you're in a public health agency, you'll then look at it, say, this looks like a reportable condition, I need to do an investigation. Then the saga begins. Who's the provider? What's the phone number? Where's the fax? All of that. Instead, why can't you just use a network to say, let me just make an electronic query with a FHIR API to just get the individual data elements that I need to support what hypothesis I have about what I might need to do next. That has really energized these public health jurisdictions and made them want to participate in TEFCA in a way that that we're really gratified about, and we're doing everything we can to make it real for them.
Okay, we're running toward the end of our time. I want to, this is an important question to ask because it goes back to the early thinking about what ONC's role was, and it came in early, and I think it's worth teeing up. Why didn't the federal agencies just establish an EMR like the VA system instead of funding all sorts of EMR launches and dealing with interoperability? Just pick an approach. I think that's a great question. I think I know the answer, but I'd rather one of you answer it.
We
I
would
can
David
comment.
Brailer answer.
I think
Yeah,
David,
well,
yeah. Okay.
Well,
David had the chance.
yes, so yes, I did have the chance and chose not to. So I think there were three reasons. One was philosophical. It was a Republican administration. The one third rail that I was very cautious of, and philosophically I agreed with, is the government shouldn't be choosing technologies or choosing platforms, that it should be in the marketplace. And so, you know, the idea of picking one was just philosophically not compatible with where we were. Two, there was an internecine war going on, not just between the VA and DoD about primacy over their electronic records. There were several others in the federal government. I mentioned Indian Health Service. They had theirs. They had some from the VA, some from outside parties. At that time, there were about 40 electronic record vendors, and they were being used and supported by various agencies. And to resolve that within the government without having Congress act, which we wouldn't want them to and they wouldn't do, would be nearly impossible. And the third reason was that we were really not in a position to, well, I'll be more blunt about it. We believe the standards were further along than they really were. And so this idea that the standards are there, HL7's ready to go, all these other things, all we have to do is kind of lay down the predicate and we'll start going, profoundly misjudged where we were. And I think this was because the standards industry, if you would, didn't really consider themselves, they didn't know what it meant to be ready to go live. They were still in the academic debate stage, and what they were doing was not wrong. It was just not nearly as specific and actionable. You look at where we are today with standards, they just weren't anywhere close. So there were three reasons that we didn't choose. And I think some of those are still valid today.
So this was very much an issue at the beginning of high tech, because in theory, we could have defined meaningful use of an EHR as using the Veterans Administration or one other existing record. And even though we were a Democratic administration and probably didn't have as close as fulsome a belief in markets as the previous administration did, we did, at least I did, believe that in terms of maximizing the value of technology and preparing it for innovation, that the federal government, the government in general, could not optimize the use of technology, that we had to create a marketplace of competing systems where, and the adopters were sophisticated. They mostly had MD degrees and they were running hospitals, and they were not likely to be the victims of abuse or fraud in the process of marketing. So we thought it was the right thing to do, to let competition reign and let the best person win. I don't think we anticipated that there would be as dominant a vendor as emerged. And as someone who later on implemented an electronic health record in a huge healthcare system, I will say that that vendor won for predictable reasons, and that now there is a real need for reconsidering the level of competition in the electronic health record market. But the markets work for lots of things, and this was one where we hoped that they would work.
Okay, I'm gonna move us to a closing question because I really want to. I appreciate the history there, but I want to ask each of you to do what is always completely unfair, but as the moderator, I get to do it. So here we are celebrating the 20th year, and I do want our audience to know that there are a lot of questions and comments that have come into me that have been incredibly complimentary of the work that has been done and continues to occur. I'm not going to ask you to imagine this event at ONC at 40. That's a little too far in the future for me to even imagine, but let's go to 25 or 30, maybe 30. Imagine yourself on this panel 5 or 10 years from now. What's the one accomplishment that you think we'll be able to look back on and say we did it? And what's the one outstanding challenge that we still haven't managed to tackle? And I'd love to hear each of you give a quick answer to that, whatever comes to mind. Who's ready?
I have it in my mind, so I'll start.
Okay, please.
I think first of all, in 5 or 10 years, I'll just send my avatar. So that'll be easy. I think but the thing I hope we will have figured out is how to have an actual way that everybody has their own personal health record that tells the story of their health from birth to death in a way that resonates with them. I don't think we'll have solved system interoperability.
I was afraid that was going to be the answer. Who's next?
We'll have found workarounds is the thing, and the consumer is a really important workaround.
I can go next. I guess I would hope, like, sort of two thoughts. One is more of a tactical, like ONC centric kind of or technology centric thing, which is that we will have moved from what we think of as interoperability now, which I would argue is kind of a primitive construct, because right now we think of it as I send you data, you send me data. We really want to be moving to automation and interactivity, and FHIR APIs are getting us there, but that's where we want to be. If you look at every other industry, that's where they are. But the other thing, and the thing that I think is a caution, and it goes back to something Don said at the beginning, until we have a fundamental restructuring of the way economics work in healthcare in the US, the technology can't solve that problem. The problem is that there's not enough incentive for thinking about individuals over their lifetime. And that's where we really need to get to in order for the technology to service that.
So, Alan,
I'd like to kind of pull those two together, because back when Craig Barrett was on the advisory committee, he looked around at all of these healthcare people who were talking about how as an agency or as a healthcare system, we were going to drive that forward. And he said, you guys don't get it, because he was working in an environment where the recipients of that would be the patients, would be driving the market, and we would have to be keeping up with it. I don't know, like with Mickey, whether we're going to get to that point, but it's the kind of thing that can serve as a check to what David Blumenthal was talking about, where it's about maximizing profit. If it's about serving my health and care, not just healthcare, because only 10% of my health or less, 15% has to do with the healthcare. If it's about my health and care, of which that data is now available to me, then we won't be having the peekaboo portals where I can't pull all of my data together. And I'm hoping that by 10 years or by 2030, that whatever this AI thing is that finally seems to be becoming real, that it will enable me as an individual to understand that information and bring it down to whatever level I need to understand it, and bring in the resources in a way that can empower the individual. Whether that will be tied into a change in the economics or not, I don't know.
So I understood, Alan, your question to be about where IT would be, or the health information exchange ecosystem would be, but where ONC would be.
I'll take either one.
Thinking about the institution, I think that it is well on its way to becoming the trusted source of advice for the federal government on how to react to the ever-changing technology and opportunity that information management presents. And if it can maintain that trust, it will have succeeded. There's no way to anticipate where technology will be in 20 years. No way, in my view. But we can anticipate the need for an organization that advises not just HHS, but the White House on how to react to the opportunities that arise.
I guess I'll go. I think Mickey said something that I'll refer back to. I think we're in the second stage of the health information movement from a policy perspective, and this is about ONC and ONC and health information. The first area I would call policy diagnosis. The policymakers did not understand, appreciate, or have any interest in what health information did to their agenda. We're now in an area where I would call it health information dependent, where policies now have to have receptor sites for what's going on with standards or other things. I want it to be health information driven in the future, which means that policy starts to orient around the presence and availability of information and its portability. And that to me really begins opening up the kind of marketplace where profits do align with the kind of value we want, which is health improvement, because you can't hide the money anywhere else and you can't make it other ways. And so that kind of goes back to the founding purpose. And I feel like we're moving really measurably towards that. And I really want to see that happen.
Yeah,
Hey, Don.
I guess I'm last. I would agree with all of these things. I think to me, the big miss in American healthcare is prevention, right? If you look at blood pressure control, lipid control, type 2 diabetes, obesity, that's probably harder to do. Maybe we'll all have a shot, literally. Those things are really independent of the acute care payment system, right? And if, the APIs that we've sort of come to, the underlying health data stores we've come to, I think are, I hope, going to empower that patients actually are able to do prevention on their own and escape the sort of the trap of the current payment system. I think the other thing that is striking to me is, and the reason I went into this whole thing literally, 1980, is there's no automation anywhere in healthcare that's really meaningful. I know we have bits and pieces of it, but if you go to any modern industry, you go to your McDonald's and, see what you've ordered and, what the status of that is. We don't have that. We don't have that kind of, widely suffused automation. Part of it is the APIs, part of it is the payment incentives. But if we're going to truly have equity, which in my mind is healthcare doesn't cost as much. That's my idea of equity. We're going to need to have automation. Automation has transformed many industries. And so I hope that ONC, and I'm confident just based on prior things that ONC has done, that ONC will be able to move that along, whether it's the APIs, the policies, everything you've heard here today. But that would be my vote for the future. And I, like maybe both Davids, wouldn't even begin to predict the date.
Well, this has been so much fun for me, and I've learned a ton. David, Rob, David, Karen, Don, Mickey, all of you, thank you for all of what you've done and also for communicating so effectively. The challenges you've confronted, the accomplishments you have, the way you've approached the work, and the inspiration you draw from trying to improve the health system as a whole and not just look at information technology as a thing. It's really been a pleasure for me. To our audience, thank you for some great questions. Sorry I couldn't get to all of them. And do know that we recorded this and we'll post it within a couple of days. Just to close, in addition to my thanks to all of you as panelists, to remind our audience that we do have additional events coming up that you may find of interest. Particularly in May, we have a journal club on California's COVID-19 vaccine equity policies. These insider events are part of a membership program called Insider that'll enable you to participate in activities that go beyond the journal at Health Affairs. And you can get more information about that and many other things at our website. So again, to our coordinators, thank you for your time, for your effort. And with great appreciation, we are adjourned.
Thank you.
Thanks.
Bye all.